Hey everyone, in today's series of stretching, we'll be discussing the elbow and forearm muscle stretchings. So, few special considerations for elbow and forearm, like the several muscles they cross the elbow, like biceps brachii and brachioradialis. So, they also influence supination and pronation of the forearm. So, when we are stretching the elbow flexors and extensors, though the techniques should be performed with the forearm pronated as well as supinated. So for elbow extension, if we need to increase the elbow extension, we have to stretch the elbow flexors. So the hand placement and procedure, we have to grasp the distal forearm and with the upper arm at the patient side, which is supported on the table, we have to stabilize the scapula and anterior aspect of the proximal humerus. We extend the elbow just past the point of tissue resistance to lengthen the elbow flexors. For elbow flexion, so if we need to increase the elbow flexion and the stretch the one joint elbow extensors, so the hand placement and procedure will be, we have to grasp the distal forearm just proximal to the wrist with the arm at the patient's side supported on the table, stabilize the proximal humerus and flex the patient's elbow just past the point of tissue resistance to lengthen the elbow extensors. And if we need to stretch the long head of the triceps, we have to increase the elbow flexion with the shoulder flexed as shown in the picture. Now for wrist extension, if we need to increase the wrist extension, so we have to pronate the forearm, or we can place it in the mid prone position and then grasps and the patient at the palmar aspect of the hand. So if there is a wrist flexion contracture, it may be necessary to place the patient's hand over the edge of the treatment table, or we have to stabilize the forearm against the table. So we lengthen the wrist flexors. We have to extend the patient's wrist, allowing the fingers to flex passively. So we are not doing extension at the finger level. We are just increasing the wrist extension, or we are stretching the wrist flexors. For radial deviation, so if we need to increase the radial deviation, the hand placement and procedure, so we have to grasp the ulnar aspect of the hand along the fifth metacarpal and we have to hold the wrist in mid position and we have to stabilize the forearm and radially deviate the wrist to lengthen the ulnar deviators of the wrist. And if we need to increase the ulnar deviation, we have to deviate the wrist ulnarly to lengthen the radial deviators. Now special consideration for the digits or the small joints of the hand. So the complexity of the relationship among the joint structures and the intrinsic and multi-joint extrinsic muscles of the digit, they require careful examination and evaluation of the factors that contribute to loss of function in the hand because of limitation of motion. So the therapist must determine if the limitation is from the restriction of joints or due to decreased muscle flexibility or any adhesions of tendons or ligaments are there. And the digits, they should always be stretched individually, not simultaneously. If an extrinsic muscle limits motion, then we lengthen it over one joint while stabilizing the other joints. And then hold the lengthened position, stretch it over the second joint and so forth, and until the normal length is obtained. Now carpometacarpal joint of the thumb. So if we need to increase the flexion, extension, abduction or reduction of the carpometacarpal joint of the thumb, we have to stabilize the trapezium with the thumb. This is a wrist bone and index finger. Then we grasp the first metacarpal with the other thumb and index finger, and we move the first metacarpal in the desired direction to increase the flexion, extension, abduction and adduction on the carpometacarpal joint of the thumb. Now small metacarpal joints of the digits, if we need to increase flexion, extension, abduction, adduction of the MCP joints, we have to stabilize the metacarpal with the thumb and index finger. Then we have to grasp the proximal phalanx with the other hand, and then we have to keep the wrist in mid position, and we can move the metacarpophalangeal joints in desired direction for stretch, like we allow the interphalangeal joints to flex or extend passively. So for proximal interphalangeal joints and distal interphalangeal joints, again to increase the flexion extension, we have to grasp the middle or distal phalanx, and we have to stabilize the proximal or middle phalanx with the other thumb or the finger, and we move the PIP and DIP joints in the desired direction for stretch. Now for stretching specific extrinsic and intrinsic muscles of the fingers, the hand placement and stabilizations are almost same, and it is used with the passive range of motion. Like this is the elongation of extrinsic muscle of the hands, like for the flexor and extensor digitorum muscles. So we have to move the distal interphalangeal joints and stabilize it. Then we move the proximal interphalangeal joint and we hold both these joints at the end of their range. Then move the metacarpophalangeal joint to the end of the available range. Then we stabilize all the finger joints and begin to extend the wrist. When the patient feels discomfort in the forearm, the muscles are fully elongated. This is for extensors.